Hey everyone, welcome back to the channel. Paul Comer here, MD4, Cooper EMS Fellow with Cooper Medical Command. Let's talk about seizures today. Let's just get right into it. All right, well, what are seizures? Well, if you want that long, boring textbook definition, then, well, an episode of abnormal neurologic function caused by inappropriate electrical discharge of brain neurons. I think that's just a really roundabout, exhausting way to say that you have uncontrolled neuronal electrical surge. The electricity in the brain goes haywire, everything starts firing, all that firing sends these abnormal signals to the rest of our body, and we have that shaking seizure activity that we see. Well, why does it happen? Well, vast majority of our patients with seizure activity have what we call primary seizures, or we just have no idea why you're having seizures, right? At some point in your life, you had a seizure, you got admitted, you got this big workup, CAT scans, MRIs, EEG, blood tests, sleep studies, the whole 9 yards, and no one can figure out why you're having seizures. Here's your Keppra. Sorry about your seizures. Have a good day. But there are some secondary causes of seizures that we should think about. Any sort of structural change in the brain or any sort of mass in the brain can irritate neurons and cause them to have irritable foci and abnormal areas of electrical discharge. And if you have an irritable foci or an irritable neuron and it fires abnormally for some reason, well, that's enough to trigger your brain into a seizure. Prior strokes or any sort of change in the makeup of the brain, again, similar to the structural or mass, you have irritable areas of the brain. If you watch the syncope lecture and you remember back to that slide where we looked at normal heart myocytes and what a healthy heart looks like, and we said that all those myocytes are designed to transmit electricity kind of smoothly and organized throughout the heart. And then we looked at the heart that had some sort of ischemic disease with it, and there's all that fibrotic tissue, scar tissue scattered in there, and that kind of interrupts that nice organized flow of electricity. And those myocytes that are kind of on their own, little islands in the area of all that scar tissue can be irritable and they can discharge abnormally and cause runs of VT. Well, same thing in the brain, right? You have areas of brain neurons that can be irritable for whatever reason and discharge and cause seizures. You can see here, this is a CAT scan of a patient who's had a stroke in the past, pretty devastating stroke. It looks like you should see this gray brain matter tissue everywhere. Here it's kind of darker because the tissue's not there anymore. It died in the stroke. So all of these neurons that normally aren't kind of just up and floating around in, the skull that used to be part of a more complex neuronal network prior to the stroke and their neighbor neurons died. Well, they're all irritable areas and prone to seizures. Any sort of metabolic change can cause seizures. We think about this classically in like our hyponatremia patients or our low sodium, so grandma, grandpa from the nursing home, tea and toast diet. Withdrawal is something that we can easily forget about, but something to keep on the differential in these patients. The severe end of alcohol or benzo withdrawal patients can really have refractory seizures and, delirium tremens territory, really high morbidity and mortality. And then eclampsia, really anything pregnancy is bad, but pregnancy and seizures is certainly horrible. All right. Here on the right side of the screen, or sorry, left side of the screen, you see this bright white golf ball thing with all the darkness around it. This is a tumor, and all of this surrounding it is edema or swelling. Normally, when we look at a brain, we like to be able to draw a midline through the brain and see that's nice and midline. You can see here the swelling is kind of pushing that brain out. So we're pushing neurons, we're stretching them, we're pushing them into places where they shouldn't be. They can get irritated and trigger a seizure. Same thing here on the right side of your screen. All this bright white is blood in the ventricles and in the tissue of the brain can irritate those neurons and cause abnormal seizure and electrical discharge activity. When we think about seizures, we think of them in a couple different flavors. The thing that most of us think about would probably be generalized seizure, tonic-clonic seizures, grand mal seizures, whatever you want to call it. It's kind of the entire brain lighting up, all the neurons lighting up and causing all of our muscles to kind of shake and react. If you've ever seen a patient had a seizure from start to finish, you see that they initially kind of get like really stiff and then they start having all these weird convulsions, body-wide convulsions, because the entire brain, again, is lighting up. There's that loss of consciousness associated with it. And then there's that postictal period, right? So their entire brain just got fried by abnormal electrical discharge. Of course, they're going to be a little out of it, a little confused afterwards. And then you can think about partial seizures, depending on what textbook you read or really how nitty gritty and into the woods you want to get with partial seizures. You can have partial complex or simple partial. And let's just keep it simple and say partial seizures for our scenario is isolated abnormal electrical discharge in one area of the brain or like a focal area of the brain, right? So consciousness isn't usually affected. depending on where the discharge is happening is really going to determine what kind of symptoms you're having. So, if it's in the motor area of your brain, you may just have arm shaking. And these certainly can progress to generalized seizures, but sometimes they don't. Sometimes you'll have a patient with a partial seizure who knows they get isolated arm shaking with their seizure, and they say, yeah, this is just a seizure for me. And it's pretty weird, but it happens. Just to prove to you that depending on where the discharge is happening in the brain can really depend on what manifestation you're physically seeing in the patient. Isolated is just the arm area of the motor cortex of your brain, then yeah, you're just going to have isolated arm movement. But if it's in the visual cortex of your brain, you might have some abnormal visual changes. If it's in the auditory area of your brain, you might hear ringing or hissing noises. So when we're thinking about seizures, kind of like worst case scenario for us would be status epilepticus. And so there used to be this definition of status epilepticus that it was a single seizure lasting more than 30 minutes. And I'm sure that some of you watching this video have heard that definition at some point. And if you've heard that definition, or if you still think that's what the definition is, get it out of your brain. It's no longer the definition of status. It's a really silly definition of status because no one here is going to sit and wait for a patient to be seizing for 30 minutes before we're like, oh, yep, that's status. Let's do something about it. So now there's a much more reasonable, much more practical definition of status epilepticus, and that is a single continuous seizure lasting greater than 5 minutes, or 2 seizures without return to baseline in between. So you have a seizure, you're a little postictal, but you never get back to your normal baseline, and then you have another seizure. And this second half of the definition, 2 seizures without return to baseline in between, comes in a couple different flavors. Certainly, you have your status patients that are seizing for a few minutes, stop for a couple seconds, and then go back into a seizure, and they're very, very sick and end up getting intubated and put on a bunch of medications and drips. But you oftentimes can also have technically a status epilepticus patient who has a seizure, comes back to their out of it. They're a little confused, but they're like, they're talking to you. They're able to protect their airway. They're just still a little confused and not at their baseline yet, and then they have another seizure. And technically, that patient is a status epilepticus patient. And there have been patients in status epilepticus that, are in a regular hallway bed or go to a regular floor bed and just need some medication tweaking or a little bit longer to come out of their postictal period for whatever reason. When we think about like the pathophysiology of seizures, well, you can kind of think about it as a kind of a downward spiral or a vicious spiral of seizure death. So you have your seizures and you have all that abnormal electrical discharge. And then you start to have receptor changes on your brain and the neurons that decrease your seizure threshold. In other words, it makes it easier for you to have a seizure. So you think about receptors on the brain and neurotransmitters or the chemicals that kind of tell the brain what's going on, talk from neuron to neuron. You kind of come in 2 big classes or 2 big families. So there's the excitatory ones and there's the inhibitory ones. So the excitatory ones are, think about those as the ones that are, amping the brain up, definitely can contribute to seizures. And the inhibitory ones are ones that slow the brain down, cause it to chill out, and maybe cause it to be a little more comatose. And, for example, so examples of inhibitory or things that kind of enhance inhibitory neurotransmission in the brain would be things like alcohol or benzos, right? Kind of like a decreased level of consciousness, sleepy. But when we have seizures, those receptors actually change. And interestingly enough, the neurons can change the quantity of these receptors depending on what's going on. So when we have seizures, the neurons are actually going to start to take those inhibitory receptors in, meaning that now we have an abnormal proportion of excitatory receptors in the brain compared to our inhibitory receptors. So now that's why our seizure threshold is greater, because we have less receptors in the brain that are taking in signals to say, hey, chill out, calm down, and more receptors in our brain that are taking in signals to amp it up. Then with continued seizures, you start to have a change in your blood-brain barrier, that barrier in between the vessels in your brain that's really responsible for being very selective and protective of your brain, only letting a few chemicals in and out of it. So that gets damaged, it gets a little leaky, more toxins are allowed in. You have a buildup of neuroexcitatory toxins, and because we have more excitatory receptors in our brain, well, then that's going to lead to more seizures. And then outside of the brain, there are other effects in the body. There are things like hypotension, hypoxia, hypoglycemia, and then even cardiac dysrhythmias. So it's important to kind of get ahead of this cycle and break it. Right, so how do we treat seizures? Well, the first 5 minutes of seizures really should just be supportive care and searching for reversible causes. There are tons and tons and tons of patients who have multiple seizures every single day and never activate the EMS system, never come into the emergency department. It's normal for them to have a 2-minute seizure and they break out of it on their own and they're fine. And they come back to their baseline faster because they weren't giving any sort of sedating medication. Um, so, like I said, supportive care, support the ABCs, provide supplemental oxygen. Oftentimes, I just throw a non-rebreather on these patients. Some providers opt to try and bag these patients through seizure. I find that trying to bag a patient who's seizing isn't always easy. The jaws are clenched. There's a lot of spit, a lot of secretions, a lot of frothy secretions, and they're moving around. It's really hard to keep a good seal. So I'll oftentimes just throw a non-rebreather on them, crank that up, and wait for the seizure to end. And then checking things that are easily reversible causes of seizures, things like blood glucoses and that kind of stuff. And it's really easy, and I think the tendency is for a lot of us to reflex into grabbing that IM midazolam, or if they have an IV, grabbing that IM or the IV lorazepam because it's uncomfortable to watch someone seize and they seize for 30 seconds. We're already reaching for our medications, but you have to remember that any medication we give someone is kind of like a risk-benefit analysis. And it's very possible that if we just waited another 30 seconds or 2 minutes, this patient would have broken out of the seizure by themselves. And now they can have normal postictal period instead of having a postictal period complicated by a heavy dose of a sedating medication. So as uncomfortable as it might be, it's okay to let them seize for a few minutes to see if they're going to break out of it on their own. When we start to reach that 5-10 mark, 10-minute mark in seizures is really when we start to think about medication administration. So 4 or 5 minutes is when we should start reaching for our medications. Your options, you have all your benzos, so midazolam, lorazepam. IM midazolam is often a lot easier to give because in a seizure patient, unless they already have an IV established, it's pretty hard to establish an IV in a patient and give them Ativan. We know that lorazepam or Ativan works faster, but we know that it's much easier to give an IM medication. And that time offset is actually, you save time by giving an IM medication, even though it takes a little longer to work because it would just take so much longer to start an IV and give the IV medication. Midazolam also has some other benefits like not really requiring refrigeration, having a longer shelf life, and that kind of stuff. And then obviously, if they're pregnant and you think they're eclamptic, then they need magnesium. And then we start getting past that 10+ minute mark. Well, we're going to redose our benzos, but again, that might not be as effective because we talked about the brain is taking all those inhibitory receptors off the surface. So those benzos work by targeting those inhibitory receptors. So we need to think about targeting other mechanisms that can stop seizures. So we go to other line agents like Keppra and phenytoin and ketamine, propofol, that good stuff. Like I said, most seizures are going to stop on their own. Once you start hitting that 4 or 5 minute mark, that's when they're less likely to stop on their own. And that's when you should really be reaching for your sedating medications and your benzos. Not in the first 30 seconds, but after a couple minutes of letting it to kind of declare themselves. Patients should look bad after a seizure. Their entire brain just got fried with electrical activity. They're going to be postictal. They might be a little gurgly. They might be a little hypoxic. They might need a little bit of TLC, a nasal trumpet, some suctioning, some supplemental oxygen to get them through it. It doesn't mean that they need an intubation in their airway. And seizures may be an impending sign of death, right? Have you ever heard the seizure, coma, death kind of triad where someone's really on kind of a critical point of their illness, they're sick for whatever underlying illness is happening to them, and their seizure is just kind of the brain that can't take the pathophysiology anymore. They have a seizure, then they kind of progress into a coma, and then they die. Well, if you think that's what's causing their seizure, then immediately slamming them with a heavy dose of sedating medication like a benzo is only going to speed that process up. So again, another plug to allow them to seize for a few seconds, a few minutes, and really let them declare themselves. And so for all the ALS providers watching this, intubating these patients is often the wrong thing to do. And when you think about intubating a patient who's having seizures or you think is in status, I really want you to get to maybe 2 good doses of benzos before you think about taking their airway. Like I said, seizure patients, they're going to look bad after you give them benzos. They're going to look bad after a seizure, regardless if they got benzos or not. And oftentimes they just need supportive care. They need suctioning, they need a little supplemental oxygen, they need that nasal trumpet. Sit the head of the bed up, put a roll under their shoulders, support them through it. We see this all the time in the emergency department. They have a seizure, they look bad. We put them on the monitor and kind of let them wake up on their own. Intubating patients or intubated seizure patients are really, really, really hard to care for, right? One, they're paralyzed now, so I have no idea if they're seizing. So you can roll the dice and say, well, they're not seizing. I'm going to wait for the rock to wear off in 40 minutes and see if they're still seizing. And if they were seizing that whole time, well, then that's not great because the patient was just seizing for 40 minutes. Just because they're paralyzed and not having seizure activity in their body doesn't mean that they can't be having seizure activity in their brain. And if they've been seizing for 40 minutes in the brain, then they're frying their brain, and now they have probably permanent cognitive or neurologic damage in their brain. Or you could say, well, I'm going to assume that you're seizing, and I'm going to put you in a really deep coma with all these medications and keep you on the ventilator and admit you to the ICU. And that's really not good for anyone because you're putting them at risk for things like deconditioning and ventilator-associated pneumonia. And not every hospital has an EEG, right? When I'm working at Cooper, I am lucky I can get an EEG down to the emergency department, or I can have them put them on this kind of like portable EEG monitor that reports out brainwave activity. But down at other hospitals or standalone EDs or more rural or community sites, they don't have that luxury. So patients have to be treated aggressively with all these really heavily sedating medications that can end up being worse for them in the long term. Whereas if we just kind of give them a little TLC in the first 5 minutes, suction them, provide supplemental oxygen as needed, maybe through a nasal trumpet, and they wouldn't have had that intubation. They wouldn't have had that 2 or 3 day ICU stay where now they're really deconditioned or caught that ventilator associated pneumonia. And just like with any problem, any dispatch we come across, history is key, especially in seizure patients. By the time they get to the emergency department, they're confused. They can't provide history. So it's really important the history that you guys provide and relate to us in the emergency department. For any sort of recent injury that I have to prioritize getting a CAT scan for and look for a head bleed, where there are fevers, and I have to prioritize more infectious workup and antibiotic administration. Any new medications, any anti-medical bottle and medicine bottles on the scene, do I have to worry about a overdose or a suicide attempt? Were there empty alcohol bottles around? Do I have to worry about this being really severe alcohol withdrawal and kind of tailor my treatment that way? The history you get just by looking at a scene can be very, very helpful to the patient in the long run. And then just to end, medicine is not black and white. There's a lot of gray in between. Sometimes it's a little difficult to determine whether someone actually had a seizure or whether they had a convulsive syncope event. And some easy, well, not so easy, but some things that can help you go down one route rather than the other is that seizures, they tend to have sustained tonic-clonic shaking activity, and they'll usually be, or they should be post-ictal after that seizure event. They should be confused out of it. But patients with convulsive syncope, sometimes after you have a syncopal event and that loss of blood flow to your brain, that cardiac output to your brain gets angry and it has a few abnormal discharges, and you can get a few brief myoclonic jerks that look like seizure activity, but it's just for a few seconds. It's not as sustained and rhythmic as organized as a regular seizure activity. And these patients have a quick return to baseline, so they shouldn't be post-ictal. So if only have a couple shakes and a quick return to baseline, probably convulsive syncope, really sustained rhythmic tonic-clonic activity, and confused afterward, safe bet is a seizure. All right, as always, if you have any questions, reach out to me, find me on the street, find me in the ED. Thanks.